We're starting. All right, we're doing the cardiac phys today. We'll get through as much as I can. We almost got through it all with the other group that was here. I'm using the Marie PowerPoint because I'm so familiar with it. Remember, this was the last thing we did was that we were doing the arrhythmias and effectively. What you have to understand is these are the events. What I'm trying to prep this is really understanding of these two diagrams is really to just have an idea of what they mean, and you understand really how the heart works. And then we go into some more related things about it. But again, we use the term with heart and blood vessels particularly, and some people use it in other systems as systole for contraction, that's the mechanical event, and diastole for relaxation. Okay. The whole idea of the cycle, and the cycle starts when the heart is at rest, in between beats, so to speak. Okay, one complete heartbeat. Okay, we have the atria basically contracts and relaxes, and the ventricles then subsequently follow it. Remember, it's a two-stroke pump, first the top, then the bottom. The cycle represents all these pressure and volume changes. We'll look at that. And again, just to reiterate the point, the electrical events that we went over on the electrocardiogram last time are all followed by the respective mechanical events. And so we look at this. So once it's, and by definition, in other words, the way we frame looking at cycle, we start when it's relaxed. And when it's relaxed, the heart's filling. At that point in time, when the ventricle, what has happened, and we'll go over why. The aortic and pulmonary semilunar valves are shut. Okay, that means now the blood is being allowed to return because there's no pressure per se in the atria or in the ventricles of any consequence. Those the tricuspid and bicuspid valves are open, and so the heart is what we call it passively filling. You don't have to do anything. Gravity's doing it. The force of the blood being returned to your heart, be it from the pulmonary circuit or the systemic circuit. And because effectively, once it gets in the atria, there's nothing to prevent it filling up the ventricles, and it starts to do that. And indeed, 80% of the blood that goes into the ventricle is filled then at rest when you or I are in between beats. It may seem like a lot, it's not. Each ventricle maximally holds about 4 ounces, 120 milliliters, less than you might think. And because it beats so rapidly, it sort of makes up for it, comparatively speaking. So that 80% of that 120 is about 96 milliliters. That's slightly more than 3 ounces. And indeed, all the atria does when it finally starts to contract is it tops off that last 20%, which is about 2.5, which is less than an ounce, about 24 milliliters. But it's surprising how important that last bit is because it creates the optimal environment for every time that those ventricles contract to eject the maximum amount of blood it can eject. We want it to fill maximally. We want it to contract appropriately. And when it does so, it will eject, are you ready? 70%. We call that the ejection fraction. It's not all the blood. 70% of the blood is ejected. That leaves roughly, about 70% of the blood is, beg your pardon, I misspoke. 70 milliliters are ejected. It leaves 50 milliliters in. The ejection fraction, the percentage is not 70%, but 57%. Now, maybe if you were doing business, that would be a bad business to only get X amount of basically, not necessarily profit, but efficiency out of your workers. Well, they get 43% of the time, they're really not very productive. For the heart, that works. That's what we need. We don't need it to be pump out every single ounce. And indeed, what makes it work consistently is you have blood left in after it pumps, and you have blood filling it when it's at rest. That's the desire. And you're going to see the two names we give those things are N diastolic volume, what it's filled with when it's at rest, and N systolic volume, what's left in it after it pumps. So, and I don't go crazy asking you about the numbers. I'm telling you a lot of this to increase your understanding of what I am going to have you recall. So here it is. So pressure's low. It starts midway into the diastole or rest period. 80% passively flows. The AV valves are open. The semilunar valves are closed. At that point, once it roughly gets that 80% in, that's simultaneously with the P wave. The P wave will push that last 20% in, okay? And effectively, we are very cognizant of that end diastolic volume, the volume of the blood in each ventricle that's there when finally the ventricles are just about ready to start to contract. So we want it to be in that 120 milliliters. It's all about, it's like any other muscle. We learned about this when all of us did AP1 about muscles. Muscles have an optimum length that they have to be stretched. So filling the blood that way stretches it to its optimal length for the most efficient contraction it will have. Remember that 80 to 120, it's got to be on one side or the other. If it either can't attach to all those wonderful actins and myosins, or okay, it's so contracted already it can't generate enough force with its contraction. One of those two. That's what happens. So this whole idea is that's the desirable feature. And then as soon as we reach that, the next phase will occur. We'll reach the QRS. That means that the electrical activity of the ventricles begins. They will contract very, very rapidly. It's not slow like the atria contracting. The atria finish, return to diastole while the ventricles begin to contract. That's the big player that's going to push the blood out. So as they relax, the pressures rise, and understand it's a closed system. We're talking about it for those who had micro today with me. We're talking about like an autoclave. Effectively, what happens, it's filled, each ventricle, with 120 milliliters, and at that point, they start to pressurize. No more blood's going to come in. The atria have already contracted. They're not allowing any more blood to come in. And so you have a closed chamber. As the pressure begins to release in that chamber and they're totally filled, what do? They push against those valves, the tricuspid and bicuspid valves. They push against those valves, slam them shut. First heart sound. So now you have a chamber, the volume is fixed, assuming the valves work properly. And at that point, the pressure is going to start to rise, and eventually that pressure will overcome the resting pressure in the aorta and in the pulmonary trunk, even though the pressures are different, and it will cause those aortic and semilunar valves, aortic and pulmonic semilunar valves to open, and the blood will start to eject. We call that isovolumetric contraction phase. And notice, it's super rapid. That's why that heart sound is so loud. It happens so distinctly. The ventricle is completely closed. All valves now are closed. The aortic and pulmonic, as well as the tricuspid and bicuspid. The volume is constant. They pressure up, and when it exceeds the force necessary to open, then aorta will probably start to open a little bit, somewhere between 80 and 100, but rapidly it will get to its typical. We're going to work on that 120 over 80. The sort of norm for blood pressure for the healthy, relatively young individual, and boom. Thrust open the aortic and pulmonic valves, and the blood will eject. Happy dance. At that point, they're going to start to relax. The ventricles will repolarize. The T wave, you'll see the ventricles start to relax. We are going to look at what's left, that amount of blood in each ventricle, which of course should be the same after systole. The ventricular pressure drops, causing a black backflow of blood from the aorta and pulmonary trunk that triggers the closing of the semilunar valves. And now, temporarily, briefly, effectively, we have both sets of valves closed. What happens, and this is the hard part, I think, to understand. You're going to see this, and I'm going to try to explain it. It's called the dicrotic notch. So, And I drew it up here for those out in virtual land. Effectively, it's just a generic drawing of a heart chamber with semilunar valves open and pointing out into, let's say, the aorta. It could happen in any large blood vessel, pulmonary artery or pulmonary trunk, carotid, subclavian. I understand in lab you're going to do blood vessel anatomy right next, I think tomorrow and Wednesday, or whatever that is. These are called elastic arteries, okay, known as conducting arteries. The walls are filled with elastic connective tissue. The blood is ejected as rapidly and powerfully as it is by those ventricles, particularly the aorta. It causes them to go, it's like a trampoline. You're pushing an elastic like that. And so it's going to expand something that inherently is elastic. As long as the blood's flowing out, that effectively that aorta, let's say, for argument's sake, is going to be enlarged. As soon as the heart starts to relax, there's still blood all through that aorta, particularly in close proximity to the heart. What's going to happen now, it's going to effectively rebound. It's like one of those little things called rebounders or little home trampolines you can exercise on, or a kid's trampoline. So now that rebound phenomena occurs. And so think of it, you have a tube, a very, very flexible elastic tube with blood in it, or any liquid in it, and it was out, and all of a sudden you have a squeezing force from above around it. You have, what's going to happen? It's open at both ends. We're going to have blood ejected toward the body. You're going to see that plays a pivotal role in sort of making our circulation very interesting and not nearly as quote unquote pulsatile or turbulent as you might think. So it's going to enhance and increase and prolong, make it more efficient, the blood flow leaving the heart to wherever it's going. And what's it going to do? It's going to push back rapidly because it's such a forceful contraction and a forceful rebound, and it's going to cause the aortic and pulmonic valves to close, slam shut, second heart sound. Now what happens? The blood rushes against those valves, closes them, and it rebounds off those valves like waves coming in, the undertow at the ocean. Anytime you have waves coming in, they push against the shore. And that rebound phenomena allows for that prolonged flow. So normally, if you had something that was that elastic in nature, you would expect very pulsatile nature of flow. Even though we talk about pulses, when you look at the dynamics and you see that chart I was alluding to, you're going to see we don't have that. That would be too turbulent. You're like whitewater rafting. That's bad. That makes blood clot. So you're going to see something that's like slower, going down, or nothing like that. It makes it continuous and it maintains it in that parameter typically if we use the classic numbers 120/80. Voila. That's a really pivotal point. They cause this little spike in pressure. You will see it. It is not part of the electrocardiogram. It is a pressure measurement within the aorta. It is called the dicrotic notch. So closure of the aortic valve particularly raises aortic pressure as backflow rebounds off the closed valve cusps, and it's called the dicrotic notch. And what that does, as you will see, is it enhances that flow and it effectively makes it more it's like gentle waves, if you want to think of it that way. And it really enhances its ability because remember that blood's got to go all over, go against gravity up to your head. It's got to go all the way down to your tippy toes and help it have some residual pressure to get it back, so we can do the whole thing over again. I know. You don't have to thank me. So the atria are continuing to fill even when the ventricles are relaxed, and when that atrial pressure exceeds ventricular pressure, the AV valves will open. So even as the ventricles start to relax, the atria already are, so the blood coming back is starting to push into the atria, and as soon as those ventricles relax enough that that pressure holding the atria, the tricuspid and bicuspid, the atrioventricular valves closed, is overcome. So as the ventricles, that's why it happens not as soon as the ventricles relax, but a little bit after, as the pressure starts to dissipate, they'll open up, and now you get that passive filling. And the heart beats 75 times per minute. And typically, it's a minimum of about a quarter second because of that absolute refractory period we had discussed previously. So typically, the heart, total heart relaxation lasts on the average, nearly a half a second in between times. Really, our heart beating, comparatively, the actual heartbeat for most of us takes maybe a quarter of a second. The refractory period's a quarter of a second. And we have so much reserve, and that's part of the reason. It's so important. The whole idea of the rest of this chapter is to sort of explain how it works and why it's so important to take care of it. And as I said to the other group, unless you're someone who has a loved one who's young and experienced an illness, maybe some severe act. It's been my experience, and this is opinion, that young folks are not, on average, I know I wasn't, very in touch with your own mortality. You don't think that something tragic is going to happen. You don't think you're going to get sick and have something terrible, unless it's touched you personally for some reason. And hopefully it has not. So, I mean, frankly, it would be surprising if you all weren't healthy now. It's the time to start thinking about it, rather than waiting like some idiot who smoked for 40 years and didn't start to do anything about it until he's 55 years old. Not that you would know anybody smart who would do something like that. Only an asshole would do that. Not to be critical. Which is why, yes, last night and Saturday night, where was I? In the gym. It's killing me. No pizza for me, Jim. What do you have for dinner? Salad. It's not fair. I demand a recount. But I digress. Here it is. So take a look. This is that dichrotic notch. The green is measurement of aortic pressure. It's not an electrical activity. Somebody put a pressure sensor in there. And you can see what happens. The pressure in the aorta drops as the heart begins to, and here's the start of the relaxation. You're going to see down here, the atria begin to fill and increase pressure. Up here, okay, the pressure in the ventricles themselves and in the aorta are dropping. Now, this is the first heart sound. So what's happened here, if you want to superimpose it? Right about now, that's where the P wave is. So the aortic pressure is dropping, but now you're getting that additional sort of filling or volume from the start of the P wave and the atrial contraction or the atrial systole. And as soon as that's over, now look, there's that heart sound. So what happened right about here, this was the end of it, and this would be about right where the QRS complex occurred. And as you can see, the pressure, because the ventricles are so large, the pressure occurs rapidly. So we see a tremendous increase, rapid, in the pressure of the ventricles that are there. And so you can see the atrioventricular valves are closing. The pressure rises. The pressure rises so much that effectively it overcomes now the resting pressure around 80 in the aorta and begins to open it up gradually. And by the time it gets to right about here, look what happens. Now you're going to have, this is sort of like the maximum level. And that's, as we're approaching, we're not even quite there at 120. And it will rapidly start to, since the doors are now wide open, so to speak, it'll start to empty, and empty relatively quickly. The pressure will drop in the aorta. The pressure will, and the volume will begin to drop after it peaks in the ventricles. But look what happens. Now as the ventricles are now relaxing by this time, they started here, they start to relax shortly thereafter. As they begin to relax, what happens? Boom, we get that residual wave, that rebound effect in those elastic arteries, and we get this sort of dichrotic notch. And so rather than being up and down, it lowers a little bit. We subtly raise it, go again, and we just keep rinse and repeat. As you can see what happens with that dichrotic notch is almost exactly simultaneous with second heart sound, the closing of the aortic and pulmonic valves. Look at it here. Here's that P wave. Remember, that was when we got the atria filling up. Then, as soon as that P wave ended and we got to the QRS, and again, electrical events preceding mechanical events. Now the mechanical events raise it up. There's that dicrotic notch. Okay, and now you can see the ventricles start to relax. We would have expected the pressure in the aorta to go all the way down, but it doesn't. It doesn't, because we don't have this. The vessels are elastic in any event. As all of your blood vessels have a fair amount of muscularity, they're not going to go all of a sudden widen like that. And this one particularly not so. And here you can see what happens with the volume in the ventricles. It's ejected rather thoroughly. Not entirely, like I said, it's only about 57%. So the second heart sound, atrioventricular valves. I beg your pardon, the first heart sound, the second sound is the semilunar valves, and that's the love dome phenomenon. If you want to get technical, and this is something they do in assessment for your nursing students. Mitral valve closes slightly before the tricuspid, the aortic valve slightly before the pulmonic valve. I mean, if you want to think of it that way, I think a lot of it has to do with the increased muscularity of the left side of the heart compared to the right side of the heart. And you'll need to learn these if you're doing physical assessment, because they're going to expect you can't be listening for the mitral valve if you have your stethoscope up here. That's one thing when you do your competencies, that'll be, oops, ding. Okay. You don't want to be dinged. So heart murmurs we talked about, abnormal sounds that are associated with this phenomena. Okay, when it hits an obstruction, the obstruction can be an irregularity in the valve where it begins to, it doesn't close properly, it's irregularly shaped. And again, that causes even tiny amounts of turbulence or irregular flow, not smooth, predictable flow occurring. And we hear that as abnormal sounds. So and I'm no good with the sounds. They describe this as a swishing sound. You can understand, I think, the stenotic valve, the one that's too taut, commenting about a high-pitched sound or a clicking sound. I'll buy it. I don't know how to hear it, and I'm sure if my ex was in better health, and she'd probably come in and tell you what it sounds like and show it to you. Back from her days when she was teaching this type of stuff in nursing. To the cardiac output, very important. This is really the take-home points. This is more the testable material. What occasions the heart sounds to occur, what valves are involved, okay? Sort of that sequence of events, what's the dicrotic notch? Those are all relevant questions, okay? This stuff is too. This is really important. This is cardiac output. Cardiac output, the definition is the blood pumped out by each ventricle in a minute. Wait till you get to respiratory. We talk about something called a minute volume. Similar, but not the same. The minute volume is the amount of air that your lungs have to move in and out in a minute. You shouldn't be surprised. They have to be equal. It doesn't matter what you're doing, whether you're at rest or whether you're exercising. We always have to marry the amount of activity our lungs are doing, read that as moving how much air per minute they're moving in and out, to how much your cardiac output is. Just the way if you're going out for a run or something like that, you're going to increase, your heart's going to pump faster. You have to increase your breathing rate to bring in that oxygen. You can get rid of the carbon dioxide, of course. So it's defined as heart rate, how frequently it beats, typical average about 75, and it's stroke volume. That's that 70 milliliters I was talking about of 120 to give you that 5.25 liters roughly. And your lungs would have to do the same thing. When we get to respiratory, you'll see that reflected as minute volume. The two are forever intertwined. Interestingly enough, okay, in a non-athletic individual, this number, you can increase it. Heck, when it increased it at the gym last night, Maybe it wasn't this much, but it was more. There was no question. My pulse was up pushing 120, which is kind of my goal. And I mean, I wasn't bothering to count what it would be, nor could I. But the reality is, this is sort of where you're going. It's amazing today. The, the difference in athletes and athletic training today as compared to 30 years ago, dramatic. 40 years ago, I mean, if you paid attention, if you're like me and, looking at times and how many repetitions in the scouting combine, which was all last week for the NFL in Indianapolis, it boggles the mind. The differences of how many of these players can run as fast as they do. Enormous, enormous men. 350-pound men running a 40-yard dash in under 5 seconds. It's scary. They never, the amount of training, the way all of these type of things are done, even in people who are enormous, and we're not even talking about these people who are extraordinary athletes. And it's not just football; it's any sport. That's why we see times in swimming decreasing, increasing in track and field performance. Pick a sport, and it's just remarkable. And a lot of that has to do, and the cardiac aspect is very significant. So we call that the reserve. That's why you want your resting heart rate to be so low. You want to keep it in that 60 to 80 range if you're non-athletic. And if you're athletic, particularly an endurance athlete, a cycler, a distance runner, soccer player, who have to either constantly move, there's no rest. You need to have that heart rate be preferably between 50 and 60. And it's really an indication of training because that's your reserve. The amount of time. And there's lots of factors. The big factors are stroke volume and heart rate. And so you're going to see things that help. We want to preload it. You're going to hear the next slide probably deals with something called Frank Starling's law. That's two proper names. And that's the idea of preload. You want to stretch it. In order to load that heart, you have to be at the appropriate level of stretch to get the most efficient contraction. That's helped not only by making sure the heart has adequate time to relax, but venous return. There's a problem with your veins. If the veins are sluggish, if somebody has varicose veins, if somebody has diseased veins, if they're overweight and the blood is creating backflow problems, it limits venous return. So that increases stroke volume, as well as having the availability of increasing contact. These are things that can impact it as well. We'll talk a little bit about fight or flight, thyroid hormone, problems with calcium, which will increase the contractility and even lower the stroke volume, which is not a good thing, by the way. So that's some problems that could occur. And heart rate, very much your autonomic nervous system, exclusive of medications, sympathetic and parasympathetic. Sympathetic ramps it up, parasympathetic slows it down. So this is the formula. As you can see, these are the norms, and what are the big factors? So if you do the math, the ejection fraction, if you divide 70 by 120, it's roughly 57%. It's an inefficient, if you want to look at it in a global sense, but your heart, the ultimate efficiency word. So preloading it, getting it stretched, okay? It affects that end diastolic volume. That's the whole, we call it the Frank Starling. It's a relationship between loading and stroke volume, that length tension relationship. It's all about keeping it repetitive and optimal. You shouldn't have to think about it. It's the time to not think about it. When you start to think about it, and hopefully sooner than later, you'll start thinking about doing the stuff I didn't do, eating properly, exercising reasonably, minimizing bad habits, or at least, hey, look, everybody can binge on something, but, try to keep your binges to a minimum, you particularly. It's our secret. You know you are. This way, boom. Next time my daughter goes, you should have seen the pictures from her 39th birthday. Oh my God. You can't show them to the class. They're scandalous. So, preload, most important part of it, slow heartbeat, exercise, stretches it, all good. Contractility. We shouldn't have to alter it. Okay. Increased contractility lowers that end systolic volume. That's not good, because then it makes it harder for the heart to fill, and it's not going to fill maximally. Sometimes we can't avoid it because in fight or flight we produce epinephrine. Okay. So these agents that do this, sometimes they're desirable to do this, and their epinephrine and norepinephrine are certainly part of fight or flight. These are called inotropic. Inotropic implies force of contraction, positive or negative. Thyroid hormone. So people who are hyperthyroid, that is something that is certainly, and particularly if they're hyperthyroid people in fight or flight, which also causes an increase in the production of glucagon, that's a slippery slope of problems. Okay? And so all of those. We don't use digitalis so much anymore. That was a very popular heart medication 40 years ago, let's say. Now, really what you're going to see when we start, digitalis was used basically because it lowered heart rate and increased force of contraction. It had a lot of side effects. Nowadays, you can see the way we want to deal with excessive force of contraction when it's unwanted, something that I take, and everybody with high blood pressure probably takes what's called a calcium channel blocker. They've been around forever. They're a first-line treatment because, remember, the heart, just like smooth muscles, relies on calcium, extracellular calcium, different than skeletal muscle. I take one called amlodipine, the top 5 high blood pressure medication on any chart, and you're going to see that's the generic name. Of some things you're going to learn from any of you going to pharmacology is the trade name, the original trade name, and they have sometimes different manufacturers have different trade names. It was Norvasc, but now the appropriate term on the chart, even when a patient gets a report like an after visit or a discharge summary, it'll say the generic name and the trade name. Start learning these. Go home, check with mom, dad, grandma, grandpa. See what medicines they're taking. Write them down, research them. Good idea. So negative, ones that reduce contractility, and these are problems, acidosis, like a diabetic. Potassium is a minefield. Whenever it's irregular, we go nuts. And calcium channel blockers, which are being used by intent. I'm not going to do that chart. The afterload, the back pressure that the ventricles overcome to eject blood. So it starts around 80, and that's about when we start to open those valves, peaking at roughly 120. Less so for the pulmonary trunk. Why? Totally different system. That's a low velocity system, not a high velocity system. If you want to put it in Kennywood terms, that's lazy river, sandcastle terms. And when we talk, and raging rapids is more the pressure, it shouldn't be the result. We don't want to see turbulence. Just saying. Sandcastle, lazy tubes. So, all this hypertension increases the afterload. Why? Because that bottom number gets higher. And that is the ultimate. If I tell you one thing today to take home, is very appropriate with blood pressures. The single most important number on your blood pressure is the diastolic, the resting pressure in your arteries. If that number goes up, it's trouble, because that means that's a measure of how taut your blood vessels are. A heart pushing against a taut blood vessel has to work extra hard to create that trampoline effect. And what happens when it works extra hard, like any muscle, it thickens, it enlarges, it hypertrophies. Trouble is not good if you're hard. Up to a certain point, fine. But after a certain point, now that doesn't work. Because what happens is it's almost like the heart becomes muscle bound, it enlarges, and it can't generate the force. It's got, remember, it's all about that length distance thing, that 80, 120. Can't get there. Can't stretch enough. It can't benefit by the Frank Starling principle of stretchability. That's here. So that's why that's such a big number. That's what, you know, it's a little more forgiving as you get older. You get to my age, 85 to 90, you can live with. I mean, whatever. The first question I asked, what was my blood pressure? Typically, I'm having a physical, and every time they give me something, 82, 84, I'm like, okay, great, my day's made. Years ago, when I was, let's say, sizably overweight, some would say morbidly obese, it bothered me. I go to the doctor. What is the first thing you do when you get to the doctor's office? They put you on the effing scale. And then they take your blood pressure. I am so, and this is typical. You should see me at the doctor's office. The belt comes off, the wallet goes out, the keys go out. I'd go naked if possible. The shoes go. You don't have to do that. Yes, I do. And they always put in the old days before it was digital. They had the little slide thing. They put it on your old weight. And then you get on there and it would go. And the nurse would go. The more they shook their head. My blood pressure's off. Then my blood pressure's 160 over 110. What the? I just stopped that. It's absolutely true. You don't have to take off all those clothes. Yes, I do. Voila. So what are the things? When it comes to heart rate, we call it chronotropic because chronos for time. Factors increase and decrease are mostly the autonomic nervous system. There are certain chemicals and certainly there are other factors. The sympathetic nervous system, that's fight or flight. We talked about that at length in AP1. Pacemaker fires more rapidly, increases the heart rate. Again, and it's also at the same time force of contraction. So you don't have the diastolic volume that you need. Okay, the end systolic volume is also increased. So we need fight or flight to protect us. That's why it only is engaged limitedly. We can't sustain it. If we did sustain it, the damage to the heart and blood vessel system would certainly be there. So it's because of those two we can maintain the stroke volume, but for a limited period of time. The one that controls the heart rate is the parasympathetic, your vagus nerve. The acetylcholine, remember that? It opens potassium channels, just like any other potassium channels. In a resting membrane, potassium flows out. The interior gets negative. More negative hyperpolarizes it, slows the heart rate. So, and we want it. Living systems are governed. Our systems, just like the cell cycle, just like your heart, go fast. This one does not affect contractility. So that's the healthy heart has a very significant amount of what we call vagal tone or parasympathetic tone. It keeps it in check. And so the trained athlete, their vagus is really holding the heart in check. So it decreases on average minimally about 25 beats per minute with any type of attempt to improve your health. And as you can see, if we remove the vagal nerve, which you certainly wouldn't, but it's over 100 at rest. That's what I mean by governing the system. That's important. Okay, and they talk about this Bainbridge reflex initiated by increased venous return, increased atrial filling, and so there's different things. And so they sort of ping pong each other. Sympathetic is busy, the parasympathetic is not. So I wouldn't worry about that, the Bainbridge effect whatsoever. And it just takes a look at certain things that are there. So you can review the chart, basically, the chemicals that impacted epinephrine. Interestingly, it's both positive inotropic and chronotropic, both heart rate and force of contraction, It's powerful. That comes from the adrenal medulla, you'll remember. That's there. That's part of the fight or flight. That actually prolongs it. Thyroid hormone, which even enhances the effects of those catecholamines. And then we really are concerned about ion concentrations. And it's different. Understand that electrical activity and mechanical activity are different, and calcium and potassium levels influence them differently. So it'll have one effect on the electrical system, it'll have another effect on the mechanical system. And that's something, if you go into heart or you work in a cardiac care unit, cardiac intensive care, you learn more about it. Calcium and potassium, for instance, the one that scares you, here are the two that we really don't like to see. Told you before, kalemia means potassium. You're getting a very limited heart rate, and you're really at risk of arrhythmias and potentially critical/lethal arrhythmias. Hyperkalemia is no better. Okay, again, now it basically is creating such an irregularity in the electrical activity that we're not even allowing the signal to go through. It can't even get to thresholds necessarily. Okay, and then look at the calciumia, increases heart rate and contractility. So, I mean, and understand the calciumemia means in the bloodstream, the heart relies on extracellular, not like skeletal muscle, heart and smooth muscle, calcium coming from the outside. And so you're going to have to, when you get into clinical things, those who are going there, you're going to see a lot about this in clinical cases where you're going to see irregularities in calcium and potassium. Those are things clinicians, doctors, and nurses get very excited about as well. These are things you don't control. The fetal heart rate is about 120. And from the moment we're born, it steadily declines to what would be the normal rate through most of the adulthood. And then we start to see variations as people get into the really late in the aging process. So it's a little hard to predict. In general, women, faster heart rate than men. And then exercise, and temperature increases heart rate. So if somebody's spiking a temp and it's your patient and their heart rate's up, you want to note that, but you want to know how fast it is. Oh, they spiked a temp today, well, their heart rate's up X number of beats per minute. You wouldn't necessarily consider that abnormal. Hopefully the temperature will go down in that regard. And so by definition, in the absence of medications or in the absence of somebody be highly physical trained, typical person, if it's over 100 at rest, call them tachycardic, and they'll say, oh, he's tachy, and bradycardic if it's under 60. And there's lots of different things that can deal with it. This is where I stop with the other group. I'm going to stop here. There's only a couple of slides left to talk about what goes wrong, and then we will effectively be done with this unit, and we'll be leading to our next unit, which has to do with blood vessel physiology. So it should tie in nicely with what you're doing in laboratory. Thank you.
Can you post the blood work?
I will. I think I did for you.
It was the first half.
Oh, I did 17A, not B?
Mm.
Okay, make sure that's there. I will take care of it. Your wish is my command.